All right. Good afternoon, everyone. It is Thursday, January 16th, and this is Citywide Medical Grand Rounds. I'm Dr. Madeline Verhovsek. I'm the Chief of Medicine here at St. Joseph's Healthcare Hamilton, and we're pleased to be the hosting site this week. Next slide, please. So we'll start with a land acknowledgement today. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. I'll bring up the next slide, please. So we're very excited today to have Dr. Cara with us as part of the quote-unquote new recruit series. Cara's joined the St. Joe's GI group in the past year, and we will hear more about her from my colleague, Dr. Khurram Khan, who is here co-hosting with me today. She will be presenting today on the topic of navigating IBD care during critical life stages, an update on women's health. And to hear more about Dr. Prey, I'll hand it over to Dr. Khan.
Thank you, Dr. Verhovsek. It's a pleasure to introduce Dr. Cara Prey, our newest recruit and member of the GI division at St. Joseph's. She's filling in an important role as she has a focus in inflammatory bowel diseases, and she's going to be sharing some of that with us today. Dr. Prey completed her internal medicine residency at McMaster University, where she also pursued both her core gastroenterology training and advanced inflammatory bowel diseases fellowship. She currently cares for individuals with a wide breadth of gastrointestinal conditions, with a specialization in complex cases of ulcerative colitis and Crohn's disease. Dr. Prey is particularly passionate about providing comprehensive care to individuals navigating IBD during critical life stages. To further this mission, she is leading an establishment of the IBD, or inflammatory bowel diseases, pregnancy and preconception counseling clinic at St. Joseph's Hospital, where she'll be looking after those patients comprehensively. Thank you, Cara. Looking forward to the presentation today.
Thank you, Dr. Verhovsek, and Dr. Khan, so much for those kind words. So I feel very privileged to get to have this opportunity to speak to some colleagues, and most namely some internal medicine colleagues, about what I hope to do here as a new faculty member at St. Joe's Hospital. And especially as an internal medicine resident from McMaster, I learned so much during these noon rounds. So I'm super happy to be contributing to them moving forward. So just a conflict of interest, AbbVie, it's really not applicable to this talk, however. So my objectives today will be to discuss the changing landscapes of IBD epidemiology across Canada, to recognize the role of sex and gender in IBD care, and highlight the bidirectional relationship between IBD and pregnancy, and then also to consider some aspects of IBD care within the preconception, gravid, and postpartum periods. So just to start with the case, just so we can kind of frame the type of individual that I hope to be seeing in the advanced inflammatory bowel disease preconception and pregnancy clinic, we take, for example, a 28-year-old female with a history of ulcerative colitis, diagnosed at the age of 20, and she'd been she'd had very good disease control for a number of years, maintained mostly on oral therapies, like 5 ASA medications, so sulfasalazine or mesalamine. However, over the past year or so, she's had some complications, some flares, and she's required steroids with an ultimate plan that her gastroenterologist wants to start her on an advanced therapy. Her GI has recommended infliximab. She is, however, very hesitant to start this advanced therapy because she's actually currently trying to become pregnant, and she's concerned of the potential side effects. So I just want to keep this sort of case in mind as we move through the talk. So inflammatory bowel disease is a condition that is mostly seen in the outpatient clinic. So I just wanted to give a little bit of a background. What is inflammatory bowel disease? It is an umbrella term. So there are two discrete entities within or under the umbrella of inflammatory bowel disease, so that being ulcerative colitis and Crohn's disease. They are quite distinct. However, we often kind of group them together. But ulcerative colitis is continuous colonic inflammation, usually starts in the rectum and then travels more proximately, and it tends to have more of a superficial type of inflammation. So mucosal and submucosal inflammation. Possible complications include toxic megacolon and colorectal cancer. In comparison to Crohn's disease, this is a distinct entity where the inflammation can actually be affected from the mouth to the anus with skip lesions. This sort of inflammation, or the inflammation of Crohn's disease, I should say, tends to have more deeper involvement. So it actually has transmural inflammation, which leads to the plethora of complications such as fistulas, abscesses, strictures, obstructions, colorectal cancer, etc. What these two conditions do have in common, though, is that they are both chronic and progressive inflammatory disorders. They have no cure, but at this time we only have treatments. So I always like to highlight, especially, I'm a newer staff, a newer GI. So I always like to reflect on, where we came from so we can, appreciate this when we are moving forward. So as I mentioned, there's no cure for inflammatory bowel disease, but there are numerous therapies. So you can see for the, inflammatory bowel disease was first kind of described in the early 1900s, even perhaps before then. And for, until the 90s, we had such limited therapeutic options. In 1998, this is when infliximab was first approved for the treatment of Crohn's disease. And after this, there's been a huge change in the availability of medications that we have. So we waited 16 years. Then in 2014, we had this almost explosion of medication. So this is kind of twofold. So it's fantastic for our patients that we care for, that we almost laugh now that we almost have a menu of medications that we can offer to people. However, on the other side, we have to consider that all of these different medications have different side effect profiles. They have different indications. It's fantastic that we have all these medications, but it's making caring for those with inflammatory bowel disease ever so much more complicated. This is an infographic from a paper called the Stride 2 Consensus Statement. Doing an IBD talk, you're almost completely obliged to include this infographic in a talk. And essentially what it highlights is the short-term, intermediate, and long-term targets when it comes to caring for somebody with inflammatory bowel disease. Admittedly, generally as physicians, and I would say myself included, it's sometimes easier to get caught up in kind of numeric values or more objective markers of improvement. So that's like improvement of biochemical parameters. So that's whether that's inflammatory markers like CRP or fecal calprotectin, or endoscopic parameters such as endoscopic healing. But why I particularly love this infographic is that they include within long-term treatment targets to consider people more holistically, to focus on normalization of quality of life and hopefully attain an absence of disability when we're caring for those with inflammatory bowel disease. So the epidemiology of IBD is drastically changing. So currently, Canada actually does have among the highest prevalence of inflammatory bowel disease, with over 300,000 individuals in Canada living with IBD. And it's estimated that by 2035, over 1% of the population will have IBD. Interestingly, so Canada is actually considered a region that we're seeing what's called like a compounding prevalence of IBD. So meaning the incidence is stabilizing, but the prevalence continues to climb. However, one subpopulation where we do see the climbing incidence still is in children. And this is something that we have to consider when, we're transitioning individuals from pediatric care to adult care. So another question comes up is, are there sex-based differences when it comes to incident cases of inflammatory bowel disease? So this is a really neat, it's a population-based study published in 2018 in gastroenterology that included data on incident cases of IBD across 16 regions of Europe, North America, Australia, and New Zealand. And then they separated with Crohn's disease and ulcerative colitis. There were over 90,000 cases of Crohn's disease and 100,000 cases of ulcerative colitis. And you can see on this graph, so what's happening, so we have ulcerative colitis and Crohn's disease separated. Then on the x-axis, you have age groups. And then on the y-axis, you have the incident rate ratio of female to males. So the flat line in the middle would be equal diagnosis. Then if the line is the red line is above the flat gray line, that favors more women being diagnosed. So you can see Crohn's disease in early life, so between the ages of 0 and 14, it's more male predominant when it comes to incident diagnoses. Then it transitioned in the adolescent years, being more prevalent in females moving forward. In comparison, ulcerative colitis for majority of years, it tends to be equal among males and females. And you can see at around the ages between 40 and 44, this actually transitions and becomes more of a male predominant condition. So I've highlighted, some aspects of the changing epidemiology of inflammatory bowel disease, and to kind of take a step back and think, almost half of patients who are diagnosed with IBD are actually diagnosed before the age of 32. It also peaks during the years of childbearing potential. So even though the formative years are, technically between, I think, 0 and 8 years old, I think if we all reflect when we were, in our 20s, being diagnosed with a chronic medical condition that you're going to have probably have lifelong interaction with healthcare, this can be quite an earth-shattering moment in time for individuals. So this is a fantastic quote that I took from a great practical review. It's a Canadian review. Elizabeth Squirrel and Yvette Leong, who are out west, they note that Canadians with IBD face a lifetime of chronic disease management, and physicians must be prepared to equip patients with the tools to navigate life's milestones with a chronic condition. So now just to highlight some of the, how sex and gender might influence, how people perceive their chronic illness, and how it is actually might, if there are, sex-based differences in outcomes and disease complications. So this is an article published, 2 years ago now in the Canadian Journal of Gastroenterology that highlights some key differences in perception of, between males and females when it comes to mental health, quality of life, healthcare utilization, and disease complications. So interestingly, when it comes to mental health and quality of life, women are more likely to report fatigue, disorders of brain-gut interaction, anxiety, and depression. However, in the survey, men revealed that they were actually less likely to even report these sort of symptoms to a physician. When it comes to healthcare utilization, males and females are equally likely to be prescribed an advanced therapy. However, females are more likely than males to discontinue this advanced therapy due to subjective drug-related side effects. Women are more likely to have an IBD-related hospital admission, but interestingly, if you look at direct cost comparisons, the cost of caring for men with IBD is ever so slightly higher than women. Then when it comes to disease complications, males are more likely to require an IBD-related surgery, both in the Crohn's disease and ulcerative colitis population, and are also more likely to suffer complications, so that being strictures, perineal, and penetrating disease. So I always like to kind of keep this in the back of my mind, especially when I'm caring for individuals in my clinic, whether it has to do with IBD or another chronic GI condition, is that we have to be cognizant that there are inequalities in healthcare access, and we have to consider those influences to our patient and in the potentially how it might influence our care moving forward. So there are, this is one great scoping review that was published just a couple of years ago that did highlight specific IBD related inequalities in healthcare access and potential effect on an individual's experience of IBD healthcare and also their health outcomes. What I found interesting is that, there is no mention of women of childbearing age who are seeking additional information on preconception counseling or counseling when they are pregnant. Because if you look at Canada, the majority of women actually do not have access to pregnancy and IBD specialists. And even the notion of an IBD specialist is something that really has been gaining traction over the past number of years. So I want to circle back to some of the sex-based differences that exist in those with inflammatory bowel disease and highlight some elements that are unique to a woman's experience with IBD. So as I mentioned, IBD diagnosis does peak during years of childbearing potential. And this is calling back to the STRIDE 2 treatment targets for IBD that includes quality of life outcomes. That should include, if a woman wishes to do so, to have children. Some interesting data has come out that shows that there is a very high rate of observed voluntary childness in individuals with Crohn's and colitis. If you look at the general population surveys, about 6% of the general population, women choose not to have children. And then when you compare this to the Crohn's and ulcerative colitis population, in Crohn's disease, it's 18%, and ulcerative colitis is 14%. Then when these individuals are provided with a general knowledge survey on their knowledge of general inflammatory bowel disease and also knowledge during pregnancy, these individuals who choose to not have children tend to have much lower scores than those that do choose to have children with inflammatory bowel disease. So the underlying concern is potentially women with IBD, is this women with IBD who choose to not have children, is this an informed decision or is it a potentially uninformed decision, especially considering that few individuals who do have IBD, very few actually have a contraindication to pregnancy. So I'm going to kind of shift this talk and really try and highlight the relationships and interactions between pregnancy, inflammatory bowel disease, and additionally touch on fetal outcomes in those who have IBD and are pregnant. This is a very complex interaction, and I'll do my best to highlight some pertinent data that has been accumulating over the past number of years. So, before we get into the nitty-gritty of the interaction, I do think it's worth taking a step back again and thinking, what developmental milestones take place for a developing fetus. So I think we all are aware that pregnancy consists of 3 trimesters separated from week 0 to 13, then 14 to 27, and then 28 to birth. You can see in trimester 1, this is a graphic on the right side of the slide that shows the risks of structural malformations. And you can see that in trimester 1, or between weeks 0 and 13, this is the highest risk of potential major structural malformations. And following this, should there be a potential inciting event, it is far less likely for this to have this significant developmental anomaly for the fetus. Since inflammatory bowel disease is a autoimmune condition, it is a inflammatory condition, it's pertinent to make sure we highlight some of the immunologic changes that occur during pregnancy. So interestingly, during implantation and during birth, this is actually a pro-inflammatory environment. So if you think about implantation and what's happening is the embryo is actually invading the uterus, and then there is this high inflammatory burden. Then, as the fetus develops, the mom and baby then begin to kind of live in synchrony. The mom says, let's have a tolerogenic environment so that we can, move forward with this pregnancy. Interestingly, I'll touch on this again later, but many women during pregnancy actually go into remission, or they note that some subtle lower GI symptoms that they might experience get better. And this is in part because of this tolerogenic environment. So we can't talk about pregnancy without talking about the placenta, but I'll talk about it very briefly because it is very important to consider, especially when it relates to medications that we give or that we are recommending to individuals with IBD who are pregnant. So the placenta is responsible for many aspects of fetal development, most namely metabolism, waste excretion, nutrient exchange. But what we have to consider as an IBD doctor prescribing a medication to women is potential transfer of that medication to the baby. So there's two main ways that the placenta kind of exchanges its substances between baby and mom. So one is being like a primary, like a diffusion. That is the primary transport mechanism. And then the second is actually it's transporter mediated. So this is quite relevant to us because majority of the medications that we provide to women or we provide to anybody with inflammatory bowel disease are either a small molecule that could easily diffuse across the placenta, and those would be contraindicated in pregnancy. Or the other subset of medications that we give to individuals with inflammatory bowel disease are actually monoclonal antibodies, and they're large IgG molecules or proteins. And this is interesting because actually transfer doesn't begin until at least week 16, which tends to be after the largest risk of fetal anomalies. Then by week 26, fetal IgG levels reach that of maternal levels. And then at term, it's interesting that fetal serum IgG levels actually surpass that of maternal levels. So, we kind of talked about baby developing, we talked about the placenta, but how does inflammatory bowel disease actually affect individuals that are trying to get pregnant or conception? So one very well-established fact is that active disease impairs fertility. It's not entirely, there's no one underlying mechanism that might be contributing to this, but it's thought that, if the body is inflamed, it's not going to say that this is an appropriate time to get pregnant, and it actually can reduce the ovarian reserve. There's also thought that there could be a contribution of pelvic inflammation, poor nutrition, dyspareunia, and even depression. Another well-established fact is that surgical history can actually impair fertility. So there's one surgery that individuals with ulcerative colitis can often undergo, which is called an ileoanal anastomosis or a J pouch. And this type of surgery actually increases the risk of infertility threefold. Okay, but it doesn't actually affect success rates of in vitro fertilization. And just to highlight what a J pouch is, I do have a photo below here. So what happens is when someone has refractory ulcerative colitis, they'll have to have a colectomy. They're left with an end ileostomy, and then ultimately using the the small bowel, a pouch is made as almost like a pseudorectum, so that you can have, so that an individual can have continuity of their bowel. And you can imagine with the amount of instrumentation that occurs in the pelvic area, that increases the risk of potential infertility. Additionally, individuals with Crohn's disease, if they have a history of surgery, this doubles the risk of needing at least 12 months to conceive. When you compare this to individuals, or women, I should say, who have no prior history of surgery and have a history of good disease control, they can expect equivalent fertility rates to those that do not have IBD. So I just want to touch on this very briefly, but how can pregnancy affect your IBD? So I already kind of touched on this, the tolerogenic environment. So it's generally the rule of thirds. So 1/3 of women will notice no change, 1/3 of women might get a little bit better, and 1/3 of women might get worse. And one clear risk factor for a flare during pregnancy is actually ulcerative colitis. And what is the strongest predictor of a flare during pregnancy is active disease at conception. So this is why it's quite important to provide the necessary counseling in the preconception period, not only to reduce the risk of maternal flares, but what we'll touch on later is also to improve fetal outcomes. Then, interestingly, a protective factor of quiet disease during pregnancy is actually the use of biologic therapy. So that's, like I mentioned when we were talking about the placenta, those large monoclonal antibodies, they're used for disease maintenance, and it's shown to be effective throughout pregnancy. Just briefly to touch on, the effect of IBD activity and fetal outcomes, because this is, quite nuanced when reviewing the literature. But what is undeniable is that women with active IBD during the preconception period and during pregnancy are more likely to experience infants that have low birth weight, preterm birth, infants that are small for gestational age, spontaneous abortion, and stillbirth. And women who have quiescent disease, fetal outcomes reflect that of the general non-IBD population. And now, lastly, to bring together all the interactions between IBD, pregnancy, and fetal outcomes. How does IBD activity during pregnancy actually affect maternal outcomes? So the individual who has IBD, there are numerous potential adverse outcomes, but two aspects that I wanted to highlight is venous thromboembolism. So compared to the non-IBD population, so this is comparing, pregnant women with IBD to pregnant women without IBD, there's increased risk of venous thromboembolism. However, one area that lacks sufficient evidence is actually the risk of VTE in those with active IBD, and that would definitely be an important clinical question to answer. But one would postulate that the risk would be quite high. And the second maternal outcome that I wanted to bring up was preeclampsia, because this is something that's actually being highly debated in the IBD world. So whenever you go to an IBD conference these days and there is a pregnancy talk, there's always going to be, a lineup of a few people asking about preeclampsia prevention when it comes to women with IBD who are pregnant. So there was a large study using the Danish National Birth Cohort that showed that there was no difference in the rates of preeclampsia in women who had or did not have inflammatory bowel disease. However, the rates of severe preeclampsia were more than twofold greater than that of the IBD population. And admittedly, I did go, read the paper, and their definition of severe preeclampsia is quite loose, for a lack of a better word. However, they did conclude that. So the problem also often arises when a non-IBD physician feels that a woman is at an increased risk of preeclampsia, and they want to prescribe low-dose aspirin for its prevention. And the question is always, will this contribute to a flare of their inflammatory bowel disease? Fortunately, we have quite a robust study that did show that using aspirin, there's actually no increased risk of IBD flare in the antepartum or postpartum period. So this is one element that is required when caring for somebody with inflammatory bowel disease who's pregnant. Often the role of the gastroenterologist in this scenario is almost to give a blessing, to say that no, I feel comfortable giving aspirin, but often the prescription comes down to the discretion of the maternal fetal medicine physician or the obstetrician. So I presented a lot of data about, some essentially, for lack of a better word, scary things that can happen to both mom, baby, and IBD throughout pregnancy. But it's always really important to consider, what are patient priorities? What sort of information are they lacking, or what sort of information are they seeking? So to address this concern, there was this great, survey-based prospective cohort study that was done by the IBD group at Mount Sinai. They have a very robust preconception and pregnancy counseling clinic there, and they asked patients that were referred to them. So the survey was done in their clinic, what information is actually important to them. And then they separated the patient priorities in both the when an individual was pregnant and then in the preconception period. The kind of greenish boxes are in the pregnancy period, and this sort of periwinkle color is in the preconception period. And you can see they asked about, inheritance, the effect of IBD on fertility, safety of medications, control of IBD activity, outcomes for baby, delivery, breastfeeding, vaccinations, and nutrition. And you can see that consistently, safety of medication was a top priority in both the people in the preconception period and during pregnancy, and also control of IBD fertility. Then outcomes for baby was quite a high priority. Then you can imagine in the preconception period, the effect of IBD on fertility was a high ranking of importance of information that they were seeking. Okay. So the question arises is are we as gastroenterologists, IBDologists, are we properly equipped to provide this information to our patients? So this is an interesting survey that was undertaken just last year, and it looks at the global perspectives on managing IBD during pregnancy and lactation, and it's a physician knowledge survey. So it was anonymous. There were 75 questions, over 800 GIs in 36 countries. 63%, so 2/3 of individuals surveyed had over a decade of experience, and about 2/3 of individuals describe themselves as an IBD specialist. However, looking through the survey, there were high variations in the practices of caring for individuals with IBD. And when you look at the answers, there's a concern of a very high percentage of responses that actually signaled suboptimal care during the antepartum and postpartum periods. So this paper really brought to light the crucial need to address and implement educational measures when it comes to caring for this population. So I want to highlight something called the Gano registry. So this is a registry where majority of the data in caring for individuals who are pregnant with IBD and in the postpartum period is coming from. You can imagine nobody is keen to do an RCT in a pregnant woman. So a lot of it is, observational data. So it started in 2007, and the primary outcome is monitoring the safety of medications in pregnancy, then also looking at potential birth defects, adverse pregnancy outcomes, complications of labor and delivery, and then also looks at neonatal outcomes, that being achievement of developmental milestones and risk of infections in the postpartum period. So you can see these two figures on the right side of the slide that shows the individuals that have been recruited to piano. So the average age of intake is 35. And when you look at and this is updated, they're very, very good at keeping all their data updated and easily accessible to the public. You can see that I can tell you that nearly all medications are representative in this. In this cohort. So what do we have so far from piano? So we are fortunate now to have lots of data and outcomes that are available to us, and a variety of not only physician important outcomes, but also patient important outcomes. So, there's been over 2,000 individuals enrolled, over 1,700 live births, and they haven't found any increase in birth defects, miscarriages, preterm birth, low birth weight, or infant infections based on what medication mother took during pregnancy. No reductions in brain development. And then, very important, they have concluded that active disease during pregnancy was more common in ulcerative colitis and led to increased miscarriages. And there are numerous ongoing analyses. One unfortunate problem, and I think a little bit of an unanticipated issue that has arose, is that there is a surplus of data that's available, but what's happening is that all of these different organizations are coming out with different guidelines and different guidelines, consensus statements, and there are subtle but important variations. And this contributes to the kind of a degree of hesitancy and debate in treating women with IBD who are pregnant. What we can see is that preconception care does improve outcomes. Okay, so when it comes to medication adherence, things like adequate folic acid intake, smoking cessation, reduced risk of disease relapse, and like I've already mentioned, less low birth weight infants. But at this point in time, we're in a quite a transition period where, we have all this information, but we just need to build on the data that we have so that we can all have robust guidelines to confidently be treating what I would call a rather high risk population and vulnerable population of individuals with IBD. So with all of this, how are we going to deliver, pun intended, best care practices to individuals with IBD who are pregnant? So two things I wanted to touch on. So number one, what do we need globally? And this is coming. And this is, we've been waiting for months for this. There's actually a global consensus conference that took place last year that highlights pregnancy and IBD, and is a highly anticipated universal guidelines that has 40 IBDologists from every continent. There's content specialists, not just in the IBD or gastroenterology field, but also considers, grade representatives, maternal fetal medicine, lactation medicine, placental physiologists, etc., and patient advocates. And this is going to be a global recommendation that can be adopted widely, globally. So that's a global level. And now what do we need, at our community level? What I think we need moving forward, and what we are establishing here at St. Joe's, is that IBD preconception and pregnancy clinic, because I think that this is, an area that we are lacking. We have all these fancy treatments, but, we have to be able to counsel our patients to actually take the medication and, empower our patients through knowledge. what my dream is for this IBD preconception and pregnancy clinic is to have multidisciplinary involvement, starting, working with the nutrition, obstetrician, maternal fetal medicine, because we know that this will not only improve medication adherence, disease optimization, and improve maternal and neonatal outcomes. So all in all, I want to thank everybody for your attendance today, and I wanted to make sure that left some time for any questions or concerns. I wanted to kind of leave this talk quite broad because it can get very detailed, but I'd be more than happy to answer any queries or comments, and more than welcome.
Thank you so much, Dr. Prey, for a fantastic talk on a topic that is highly specialized, and yet I think many of us will come across because of the sometimes multi-specialty, multi-organ nature of some of the challenges that these folks face. Really amazing to have you here as an expert in the field of IBD and with this special focus on women's health. So I'll invite folks to enter any questions they may have into the MS Teams Q&A section. I will also encourage folks to raise a hand if their preference is to ask their question out loud. And I do see that we have Dr. Tallman with a hand raised. So let me just do what I need to do to allow you to unmute.
Hi, Cara, thanks for a great presentation. So my question is inflammatory bowel disease is, to me, quite a spectrum. It's, two distinct diseases, Crohn's disease, inflammatory bowel disease, and also colitis. And the patients that I've seen over the years are quite different in terms of severity of symptoms, etc. I just wonder, how reasonable it is to lump all patients with inflammatory bowel disease under the same umbrella with respect to some of the metrics that you're measuring.
Yeah, so that's a interesting question for sure. So if I understand correctly, it's just, it is a spectrum. Some people can have very mild disease for sure, but maybe circling back to, or bringing this back to, why do I think that someone with even very mild ulcerative colitis, why do I think that they require, counseling in the preconception, when they're pregnant or in the postpartum period, is because sometimes people will have those unpredictable worsenings. Some people might not flare during pregnancy, they might flare after. Or what's often common is that women won't tell anybody, but they'll just stop taking their medications because they don't want to get told. They'll just stop taking their medications for the fear of potential negative fetal outcomes. So if you can take some time to explain to someone that no, this medication is safe, it will, result in better outcomes for both patient and baby.
Great. Yeah, just a follow-up. So ulcerative colitis and Crohn's disease would be roughly similar in terms of the sort of outcomes and data you provided.
So again, it skipped in one, I think the most important word you said. Hey, can you repeat the question?
So ulcerative colitis and Crohn's disease would be roughly equivalent in terms of the various data that you provided.
Yeah, so there are subtle differences. So one thing is that ulcerative colitis, actually, it's thought that it's very like hormonally driven, which is why people with ulcerative colitis are more likely to flare in the when they're pregnant because of estrogen potential, increase of gut permeability, and then also the high levels of estrogen and progesterone can affect the maternal microbiome, and that can increase the risk of flares.
Great, thank you.
Thanks so much, Dr. Tallman and Dr. Prey. We have next question up is in the Q&A. I'll read it out loud. It's from Munir Mohammed. Thanks for the talk. How and when we will be able to give the newborn the live vaccines in case the mother was receiving advanced therapy during pregnancy?
Yeah, perfect. So this is a great talk, a great question. And again, this is something that is going to be included in the new guidelines. So for the non-live vaccines, that's entirely safe for baby to have. But so right now, what the guidelines say is that it's to defer live vaccines until 6 months. So the only live vaccine that would be given is rotavirus, okay? However, that being said, there is a signal that actually rotavirus might be safe to give in that first 6 months. But until that officially comes out, baby is okay to undergo their normal vaccination schedule with the exception of live ones or rotavirus after 6 months.
Fantastic. Thanks so much for that question and for your response, Dr. Prey. I'm going to hand it over to Dr. Khan, who's co-chairing the Q&A with me. And I think he's got a question or two for you.
Thank you. And thanks for the questions of the audience. It's really makes the discussion lively. I just want to actually follow up with Dr. Tallman's question. I think what you're getting at, and Cara kind of addressed it, was there is certainly a spectrum in inflammatory bowel diseases, both even within ulcerative colitis and within Crohn's disease. So there are what we call high-risk phenotypes within each disease. And certainly those would be the ones where there's a heightened anxiety about medication adjustments and really having optimization of control of the disease at the time of conception. So I think that's what you were getting at, and you're absolutely right. There are these differences and nuances within, but I think in general we treat all patients, even the milder ones, with that certain level of concern for optimizing their disease before and at the time of conception. Thanks, Cara. I mean, I just want to follow up with Munir's question as well about the advanced therapies. These patients who are on the advanced therapies, certainly some of them talk about, would like to know about whether they can cut back or withdraw the therapy. How do you explain the risk to that type of patient in terms of, or is there a patient, let me frame it another way, is there a patient that you would be okay with in terms of stepping down or withdrawing their advanced therapy during a pregnancy?
Yeah, so that's a great question because, a lot of people do ask that, they don't want to take medication. They're afraid of the potential outcome. So how I essentially present it is I say, you have to consider active disease or inflammation like a teratogen. So we don't know what's going to happen should she stop her medication, what is going to happen. But what I can tell somebody is that the medication is safe. So it's safe to keep your disease at bay. And then it's also, been demonstrated again and again in multiple studies that it is safe for baby and has no impact on, time at the time of delivery and actually improves outcomes. And then we're starting to have longer term data from Piano saying that there's no impact in long-term development of baby as well. So that's the thing. That's what's needed as well to talk with these people is time. Like often you're not really doing much in these, like you're not ordering labs, you're not, recommending a colonoscopy, you're just counseling.
Yeah, that's a great point. I think that the time and energy and having patients understand this importance of their disease control, that's critical. Similarly, in terms of we have with our biologic patients sort of that window towards the end of the delivery. I don't think you mentioned it, but is there a difference and do you recommend natural delivery or C-section for certain types of patients? That might be a useful question for maybe some OB folks on or.
Yeah, that's a great question too, because that's something that patients often ask about. So there are very few reasons that a woman would not be able to give birth her preferred way. Really, what would necessitate a C-section would be like active perianal disease or a history of severe perianal disease, because that would increase the risk of like a tear, so like a fourth degree tear. Otherwise, there is a signal for people who have active proctitis, so active distal ulcerative colitis, that it might be favorable. But again, really just that active perianal disease. And I also touched on the J pouches, so IPAAs, when people have had a colectomy and then, then they have a pouch that essentially is a rectum formed out of their small bowel. There is a thought that perhaps a C-section would be better for them, just because the potential risk of damaging the sphincter.
Thank you, Cara. That's great. I think probably the most striking thing, which I think we see more and more of, is the increased prevalence in younger patient population. And it's great to see that we're trying to be ahead of the curve, knowing that there'll be an increase in this younger demographic. Of course, the age where conception is more likely to occur. What do you tell patients about the risk? Often patients who've had the disease very young have gone through a lot in terms of the anxiety of the disease and some of its complications. What is the risk of passing on the disease to the newborn? Is that something you tell them about? Is there a genetic risk? Is it how high is that risk? And maybe that's something useful for the audience as well to appreciate.
Yeah, so that's a good question. So I would probably say most women are going to ask that question, right? And what I say to them is, so often I'll take a step back and I say, are you the only one in your family with inflammatory bowel disease? And often that is the case. So, and then I present it in a way that it's kind of, it's nothing that they did. It's just a number of unfortunate events, genetics, environment that have come together, and this is why they have their disease. There is an element of heritability. Okay, so it is fairly low though. So I usually quote around, I think like 5% is usually the number that I'll give people. But and often women will also ask, when will I know if my baby has inflammatory bowel disease or not? And I say, this is just going to be something that you might be worried about. But again, oftentimes the women that we speak to, they're the only ones with IBD in the family. So I say, look at that risk, and just to provide you some reassurance.
Yeah, I think that's great messaging, at least that it is quite low. The vast majority of IBD is, as you said, exactly sporadic. It's non-genetic. So that's fantastic. Do we have time for more questions? Dr. Vrozik, or should we let Dr. Prey?
Yeah, you can shoot if you guys. I think this is great. If you have one or two more questions, Karim, and I'll just invite a last call to the audience in case there's any percolating questions as well.
So, Cara, you mentioned multidisciplinary care. I think that's another kind of idea, if you will. We have, I believe, at McMaster now a maternal fetal medicine clinic. We have a high-risk OB clinic. Is this something, or like kind of where does the IBD pregnancy fit in? Is it integrated with those types of services, or is it more, as you mentioned, about the preconception and kind of counseling and preparing? I mean, like you said, the vast majority of patients, if their disease is under good control, should have an uncomplicated pregnancy, so long as they continue with their medications. So where do you see that fitting in, or is there a time and place where you would work together with other specialties in that area?
Yeah, I think that relationship is something that I'm hoping to build. And this is one of the reasons why I wanted to talk about this, during this, with this audience that I have, to take opportunity to make connections. Because I've been, in hallways stopping my maternal fetal medicine friends and trying to kind of brainstorm ideas and how we can connect. But this is something that, I see it almost as, as GIs, we tend to have pretty good relationships with our surgeons. And I kind of see it in the same manner as that.
Excellent. Well, there's no question medicine is a team sport. So we look forward to working together as a team. I think it's 5-2 if that works for everyone. If there's any other questions, if not, we can sign off.
Thank you so much. I'll just maybe wrap things up by thanking Dr. Prey once again for a fabulous presentation and a really great dialogue and Q&A at the end. Thanks again to Dr. Khan for joining and for his ongoing leadership in the St. Joe's Gastroenterology Head of Service role. Thanks to all of you for joining. And just briefly to announce what's up next week, we'll have HHS as the host site with Dr. Mylin Duong from Respirology. Stay tuned to your email for more details. And the week following that, St. Joe's will be hosting again Back to the New Recruit series, and it will be Dr. Noura Al-Osaimi from rheumatology joining us. So some exciting talks coming. Hope everybody has a wonderful day and an excellent week ahead.